We made it to arterioles. All right. Let's see. So I talked about compliance, and compliance is stretchability. I probably didn't use the example yet, but when you have a compliant balloon, it's a very stretchable balloon. You know those little tiny ones you do for water balloons? They're like, you go, and you blow it just a little bit and it pops open? Those are not very compliant. The big, baggy, saggy ones that you go, and you're like blowing in and keep getting bigger and bigger and bigger, those are extremely compliant. When you refer to compliance of an artery, this the more stretchable it is. Elastic is more the term of snapping back. So when something's elastic, you pull it out, you let go, and it snaps back like your waistband. When it's compliant, you blow harder, and it goes whoop, 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 real easy. It's stretchable. So there are my terms for it. Stretchable is compliance. Snap-backable is elastic. Yes, I'm going to patent those two words and put them in the dictionary. All right, we talked about systolic and diastolic. Systolic is when the left ventricle is doing what? Contracting. It's the maximal contraction, like pressure, when the left ventricle contracts. Are you measuring the right ventricle for its pressure? Nope. The volume on both sides are the same, but the pressure is very different because the left one's going where? The whole body, where the right one's only going to the lungs next door. You don't need all that pressure, which describes what it looks like. What's the visual difference between the left and the right ventricle? One is bigger, not volume-wise, but bigger in muscle mass, right? So it's bigger muscle mass for all that extra pressure. And then we talk about diastolic is when the left ventricle is doing what? Relaxing. Does your blood pressure drop to zero? No. The artery pressure never drops to zero. The heart's pressure, the left ventricle, will drop to zero. In fact, it'll create a negative pressure that starts sucking blood from the atria. But the artery should never drop to zero unless you're dead. Right. When we use diastolic and systolic, how do you calculate pulse pressure? You take the systolic minus the diastolic. That's the difference you feel pushing up on your wrist every time that it goes boom, boom, boom. You're feeling about 40 millimeters of mercury pushing up every single time. And then we can calculate MAP, mean arterial pressure, and we did this in lab too. But MAP, you divide pulse pressure by what? 3, and then add what to it? Systolic or diastolic? Diastolic. Anybody remember what the average pulse pressure is if you're 120 over 80? So you can calculate 120 over 80 is, so you subtract those two, comes out to 40, divided by 3 is roughly 13, plus 80 is 93. And this little chart talks about the pressures. You can see the left ventricle goes all the way up to about 120 millimeters of mercury. That's at its hardest. That's when it pushes the door open. You're feeling that pressure out through your artery. And then it drops all the way back down to zero. It creates that sucking pressure. So it pulls blood down from the atria. But look at the arteries. They don't do that. They go to 120 and then 80. So as soon as they hit 80, what is preventing them from going below 80? What structure closed to make sure that the blood can't go backwards? The valves. So the valves stop the blood from moving backwards, and then that elastic property, the squeezing, is pushing the blood where? Forward into the arterioles. So it slowly squeezes, the elastic property of the artery slowly squeezes the blood into the arterioles, dropping it down to about 80, and then when it hits to 80, guess what happened in the heart? You had another contraction, and now the left ventricle has hit 80 again, and now it's going to push this back up to 120. The heart relaxes, the pressure slowly starts dropping again until it gets down to 80. The heart beats again, drops again, and then beats again. It just keeps doing that pattern over and over. If you look to the arterioles, look what happens to the pressure. Here's your average pressure in the arterioles. What's happening? You have a quick drop. Why do you need a quick drop going from the artery down to the capillaries? Because the capillaries are how many cells thick? One cell. They're one cell thick. If you have high pressure down the capillaries, you're going to blow those suckers out, right? And you can actually see that when people have those spider veins. So you can see that those little capillaries are exploding in there, and they're actually pushing too much pressure. And then eventually the venules, the veins, almost down to zero when it pulls back into the ventricle. This shows you that during a heartbeat or the cardiac cycle, what do you spend more time in? Systole or diastole? Diastole, look at this. Push, go, back down. Push, relax, back down. That's why when you're calculating mean arterial pressure, you add the diastolic, because you're spending more time in diastole than systole. So if I ask you a question like this, patient has a blood pressure of 135/90, what's their MAP? How do you calculate this? So you take 35 minus 90, which gives you 45, divided by 3, which is 15, plus diastolic, which is 90. So what's it come out to? 105. All of these you can calculate if you misuse this. It's just like any other math type of equation. You have to understand how to do MAP. Okay, next structure is the arterioles. What's the first thing that should pop in your mind about arterioles versus arteries? They're smaller. Yep, they're the second in line. So the second blood vessel in line after the heart. These are the resistance vessels. When I told you I have nicknames for all of them, these are the resistance vessels. These are the ones that change the resistance. The pressure reservoirs were what? Arteries. They take that pressure, that high 120 millimeters of mercury, they store that pressure and slowly release the pressure downstream. The arterioles are what adjust the resistance. What's the best way to change resistance in a vessel? So one way to do it would be viscosity, another one's length, but what's the best way? Diameter, or the radius, exactly. So when you're manipulating these, you don't really manipulate the radius or the diameter of an artery very much. It has muscle in it, but it doesn't do a lot of constricting. When you look at the arterioles, these have more smooth muscle for resistance. So the proportion of smooth muscle that adjusts the size of this vessel is greater in the arterioles. Mass size is still bigger in the arteries, but the purpose is more important in the arterioles. So the arterioles are controlled by the sympathetic nervous system, not the parasympathetic, the sympathetic. So if I release a sympathetic onto this blood vessel, what do you think it's going to do to those muscles? What's sympathetic have a tendency to do to these muscles? Squeeze them. So what's going to happen to the size of the blood vessel? It gets smaller, it constricts. What's going to happen to the pressure? When you shrink the radius, what do you know automatically should happen to the pressure? It's going to get raised. So releasing your sympathetic nervous system does what to your blood pressure? Increases it. I put this in bold for a reason. When you think about the sympathetic, we usually say sympathetic, does one thing and the parasympathetic does the other. But when it comes to the blood vessels, every time except the last week of class, when I talk about blood vessels, I want you to think of the sympathetic. It's kind of like your car. If you want to slow down your car, what do you hit? If you want to speed it up, you hit the accelerator. It's like the sympathetic and parasympathetic. Sympathetic's the accelerator, parasympathetic's the brake. What if your brakes don't work? Is it possible to slow your car? How? Nope, no brakes, no emergency brake. Huh? And no hitting a tree. Let off the accelerator. That's exactly it. So if you only have a sympathetic nervous system to control the size of these arterioles, and the sympathetic constricts it, how can you dilate it? You don't have a parasympathetic. There's no brake to reverse that sympathetic. You just have to let off the sympathetic. When you let off the sympathetic, those muscles relax and they dilate. So that's sometimes a tricky thing to remember. Is the sympathetic controlling the blood vessel size. When you stimulate it and it constricts the blood vessel, the way to reverse it is just turn off the sympathetic and it reverses the process. Right? So vasoconstriction is telling you what's happening with the sympathetic. Turning up. What's happening to the size of the blood vessel? It's getting smaller. What happens to your blood pressure when you vasoconstrict? It increases the pressure, right? You're trying to maintain flow, so if you increase the resistance, what do you have to do to pressure? You increase it with it. How about vasodilation? What are you doing with the sympathetic nervous system for vasodilation? Reducing the sympathetic. What's it going to do to the size? Increases the diameter of the radius. Yep. What's it going to do to your blood pressure? Relax it. Okay, vascular tone, we talked about this. The tone is that tension that you create in the muscle. What type of muscle is surrounding a blood vessel? Skeletal, smooth, or cardiac? It's smooth. Remember, cardiac's just in the heart. Even though we're talking cardiovascular, smooth is what's around the blood vessels. So you have that myogenic activity. A quick expansion makes it want to do what? Squeeze back really quick. So that myogenic activity means muscle-generated activity. It's the muscle controlling it. Would that be an extrinsic or an intrinsic controller? It's intrinsic. It's the blood vessel wall controlling the blood vessel wall. It's intrinsic. It's within the blood vessel. So what would sympathetic mean? Intrinsic or extrinsic? It's extrinsic. It's what system controlling the cardiovascular system? It's the sympathetic, the nervous system controlling the blood vessels. It's an extrinsic controller. Okay, and then here's just a visual again. So in this situation, what's happening from here going this way? What am I doing to the sympathetic nervous system if this were the analogy? I'm slowing down the sympathetic, right. So if I crank up the sympathetic, what do I do to the flow to this organ? It slows the flow. That's interesting because when you think of the big picture, if I'm terrified, what happens to my skin color? Why? Because the sympathetic nervous system did what to those blood vessels? It constricted them. What did it do to the flow? It decreased the flow to my skin. Why did it decrease the flow to the skin? What's it trying to do? Send it to the heart and the brain and the muscles. It's trying to redirect that flow. So when the sympathetic comes out, it's interesting because it squeezes these blood vessels. It's going to squeeze your deeper blood vessels too because it's trying to squeeze and push the blood up to your heart and to your brain. So think of that sometimes. Think of the sympathetic nervous system. What are your physical responses? Your pupils dilate, you start sweating, your blood vessels constrict. So what's it do to the skin? If the blood vessels constrict, it must turn down the flow, which makes it look pale, right? What's it do to the flow to the brain? It increases it. Yep, it increases the flow of the brain. What's it do to the flow into the heart? Also increases it. Remember when you squeeze the blood vessels, even when you're talking about the veins, squeeze the vena cava, it increased what? Was that called preload, afterload, or contraction? The preload. Yep. So I keep throwing back concepts we talked about last week and the week before because you just have to understand them. Okay, so when the heart squeezes, when the heart pumps, it squeezes all equally to every organ. It's the arterioles that are adjusting the flow to each of the organs individually. So this is the key down here. Heart delivers the blood to all the organs at the same mean arterial pressure. The heart does, but what adjusts the resistance? The arterioles. The arterioles adjust the resistance. That's why they're called the resistance vessels. So if my kidney needs more blood flow to it, does it tell the heart beat harder? Nope. It takes those little arterioles that are going into the kidney and does what to them? Opens them up. It increases the flow to the kidney. And this is a concept that we're going to have to talk about when we talk about the kidney too. So when we say that you're decreasing blood or urine output, what's going on with the flow into the kidney? It's decreasing, exactly. You're getting less blood flow into the kidney, which means you make less urine. So concepts will keep coming back. Every organ in your body has an arteriole going into it. It's the arterioles that help adjust the flow into that organ. Even your muscles. If your muscle's not being used, like if you ran on a treadmill like this, with your arms hanging, guess what color your arms just start turning? They start turning pale. Why? They don't need it. You're not using your arms. They're just dangling there, right? Your legs are going to start turning red. They're going to start swaying like crazy. Your armpits are going to get hot too because your core is getting hot. But your arms dangling at your side like that, they're just going to turn pale because you're not using them. What's happening to the blood flow? Decreasing it. You don't need it. You redirect it to where you need it. What are the name of the vessels that are doing that? Arterioles. So I kept talking about the heart and the brain, and it's actually the brain's the only organ that has a consistent blood pressure all the time. Whether you're sleeping, whether you're exercising, it's always the same pressure. Flow is a different matter. We use an MRI to detect flow in different parts. We can adjust the flow, but the pressure is always consistent.
Is that the CPB? Is that the CPB?
CPB.
Cranial
Blood pressure?
Yeah.
That would be consistent with a cranial blood pressure. It should be consistent all the time. The flow changes with an MRI. Yeah. You're talking from an EMT perspective, aren't you? Yeah, when that changes, that's a pathophysiology situation. Because if you start changing blood flow into the brain, what do you start doing to the pressure in the brain? Yeah, if you start cranking up the pressure in the brain, is there a lot of room for expansion of those blood vessels? No, it's going to start smashing your brain. And you start seeing weird things like pupil changes and everything. Yeah. Yeah, that's more of a pathophysiology concept. Okay, so which factors cause vasoconstriction? Look, there's a list. And there's going to be a list for vasodilation too. One of the easiest ways to look at this is you have to know or memorize one side of it, and guess what the other is going to be? If vasoconstriction does one thing, vasodilation is going to be something almost opposite. So if you increase myogenic activity, so in other words, if I start stimulating this muscle, I expand it, what's it want to do? It wants to constrict back down. So if I push a lot of blood flow into this area, that muscle instinctively, or how would I say that? Extrinsic or intrinsic? It intrinsically squeezes back. So the muscle is going to do it. If I rapidly stretch the muscle, you have this myogenic activity that increases and squeezes the blood back down. And again, when we talk about the kidney, I'll talk about that again. The kidney has these little tiny structures that are one blood vessel or one cell thick in the blood vessels. What would happen if I suddenly started exercising and I increased the blood flow to my kidney really rapidly? What would happen to those little blood vessels? They'd rupture. Yep. So we'll talk about that again. When you increase the blood flow really rapidly into some organs, they can't handle it. What are they instinctively going to do? They're going to have that myogenic activity and the arterioles are going to constrict back down so that you can't blow out things like your alveoli in your lungs or your glomerulus in your kidney. Or brain for that matter. All right. Next, increased oxygen, less need. So if you have more oxygen, do you need more blood flow to that area? If you have more oxygen in that area, do you need more blood flow to it? No. So what do you do to the size of the blood vessels? You squeeze them down. What's it doing to the flow? Turning it down. Remember when I was telling you running with your arms dangling at your side? Do these muscles in my arm need a lot of blood flow? No, they have plenty of stored oxygen in the myoglobin, so they're like, hey, we're full. Just redirect the blood somewhere else. They vasoconstrict their arterioles so that it redirects the blood flow to other organs. If there's less need for flow here, you start squeezing it down. Number 3, decreased carbon dioxide. So when you see an increase in oxygen, you usually see a decrease in carbon dioxide. But if there's very little carbon dioxide in an area, what's that telling you about the muscle's activity? It's not very active. Yeah, it's not very active. Carbon dioxide is one of those byproducts of metabolism, right? So when you increase the metabolism, you're making more ATP, you're burning more oxygen, you're making more CO2. It's just a natural byproduct. If you're not metabolizing, you're not working the muscle, you don't need a lot of oxygen because there's already right there. You don't need to get rid of carbon dioxide because it's already really low. So number 2 and number 3 are just basically two sides of the same coin. Number 4, increased endothelin. This one you've never seen before. Endothelin is a chemical. Endothelin's kind of cool. When I was in grad school, I worked in a lab where there was a guy that studied endothelin, and it's the most powerful vasoconstrictor that we know on the planet. And your body makes it. It's comparable to snake venom. That's how strong this stuff is. It's a little chemical released by the endothelial cells that causes vasoconstriction. When you get bit by a snake and the snake venom gets in you, the snake venom starts causing massive vasoconstriction. It's squeezing all of your major blood vessels, and it's smashing it, all that blood, into the capillaries where you don't want to push it. What's that doing to the pressure going into the capillaries? It's increasing it. What's going to happen to the capillaries? They're going to start rupturing. So when somebody gets a snake bite and you start seeing, they start getting pale around the area downstream of it, but their eyes, they start getting like bloodshot eyes. They start getting like the little bursted capillaries in their face. Why is that? Because this chemical is doing what to their blood vessels? It's squeezing all of them, and it's squeezing them all evenly so that it's pushing all of the blood into the capillaries, and it's going to start blowing out the capillaries. But this endothelin stuff is in your blood vessels, and it's released in a case of emergency. If you need to rapidly constrict a blood vessel, little tiny bits gushed out. Not like drops of it, like in snake venom, but microscopic amounts are pushed out to squeeze the blood vessel down.
So like when would you
well, in a situation where that blood vessel might start incurring damage, it'll start releasing endothelin to cause constriction. If you have a cut in that area and you want to decrease the blood flow downstream, you'll release a little endothelin to squeeze that blood vessel down. Yeah. If there's too much, it will actually close the whole blood vessel off. But when you're talking about one cell in your body releasing a little bit, it's not that powerful.
I'm sorry, can you explain myogenic activity again?
Yep, myogenic means muscle-generated activity. Remember that whole situation with the stomach when I told you if you drink a gallon of milk and expands it really quick, what's it want to do? It wants to go back. It's the muscle generating this constriction. So it's not outside of the muscle, it's specifically within the muscle. It just wants to go back to its normal size. If you slowly expand it, it's okay. But if you rapidly increase it, it snaps back really fast. Yep. Yeah, if you guys have questions, make sure you let me know. Okay, so endothelin, it's a chemical that's released. It's actually called an autocrine or a paracrine chemical, if you remember that from anatomy or from a biology class. It means that the cell will actually release it to stimulate itself or to release this chemical to stimulate its neighbors. It's kind of an interesting thing. It's like the cell talking to itself. It wouldn't actually be a positive feedback loop unless it released more endothelin in response to the first endothelin release. I don't know who asked that question, but I'm just looking at that general area. Yeah. I like that you're thinking feedback loops, though. Number 5, increased sympathetic stimulation. You already know this. You know if you dump what chemical on the blood vessel. Epinephrine or norepinephrine, right. So you want to think NE for norepinephrine or EPI for epinephrine. That's the shorthand you'll see all semester in the future. That's what, EPI for epinephrine and NE for norepinephrine. And that's why they call it an EpiPen. So sympathetic stimulation, if you release epinephrine or norepinephrine onto the blood vessel, it constricts. If I give you a shot of epinephrine in your leg, it doesn't matter where the epinephrine came from. What's going to happen to your blood vessels? They're going to constrict. What's going to happen to your blood pressure? It's going to go a split. You guys split me right down the middle. What's it going to do? If you squeeze the blood vessels, it has to go up. When you give somebody an EpiPen, why do they usually give that to them? Because of shock or, well, actually different types of shock. Allergic reaction, like an anaphylactic response. Because histamine, which we're going to see on the next slide, histamine does what to blood vessels? It dilates them. If you have a lot of histamine in your blood, what's happening to all your blood vessels? They're getting bigger. What's happening to your blood pressure? Dropping. Where's the blood going if you're standing up? To your feet. All those blood vessels get big. The blood goes to your feet. You get really lightheaded. And then eventually it's not only not getting to your brain, it's not getting to your heart. Exactly. So if you give them a shot of an EpiPen, what's it do to all their blood vessels? It constricts them. What's it doing to the blood? Pushing it back upwards. Pushing it into their brain and back into their heart. So there's your little pre-pharmacology piece of advice.
Is that why people in shock are instructed to lay down?
Yep, that's exactly why they tell them to lay down. Or elevate their feet. What's the name of that term where you put them on a stretcher and you elevate their feet slightly? There's a name for it and it's been so long. Are they? See how old school I am? It's been a long time since I took AMT classes.
I used to get hives really bad, so they got a stroke. You don't know why it like makes your heart go like crazy. Is that why? Because they're trying to get it?
Yep. Yeah, and that's why, right, when you get an epinephrine shot for like an allergic situation or whatever, that's why your heart starts racing really fast because that epinephrine's in your blood. Anywhere that there's a receptor, it's going to work. So, does that make sense? Yeah. What's it going to do to your GI tract, by the way? It's going to slow it down. What's it going to do to your urination? Slow it down. Yeah, so there are interesting other side effects. So if you take too much epinephrine or you're really stressed for a long time, you're releasing lots of epinephrine, what happens to your GI tract? Slows down. So the next time that you see something that looks constipated, you can go, oh, honey, you look so constipated. You must be really stressed. Right? And number 6, increased vasopressin and angiotensin. You underline these. And I'm having you underline these 3 words because they're technically groups of hormones. Anytime you see a hormone throughout the semester, you have to memorize it. You just have to. There are 2 major control systems in the body. One's the nervous system, and if you've noticed, we're beating this one to death. Every week we talk about the nervous system. And every week we're going to start talking more and more about the endocrine system until the second to last week of class is when we're really going to go into it. Vasopressin is a hormone. Guess what it does to blood vessels? Vasopressin increases blood vessel pressure by constricting, right? The other word I want you to write down is a 3-letter word underneath vasopressin. It's also known as ADH. ADH, like antidiuretic hormone. Think about this. This is the same chemical, but 2 groups of people labeled at the same time, so they just kept both names. What's antidiuretic hormone going to do to you? It's an antidiuretic, right. You got the diuretic part right, but anti means it's going to make you hold water. Holding water is going to do what to your blood volume? Increase it. What's going to do to your blood pressure if you have too much blood volume? It increases it. Everything about vasopressin is trying to do what to your blood pressure? Increases it. It works on the kidney by making you retain water. It works on the blood vessels by squeezing and vasoconstricting. This is going to be an important hormone that we're going to talk about lots of times this semester. Vasopressin, here's a fun fact. We'll talk about when you go out on Friday night and have a couple beers. Vasopressin is the hormone that actually makes you break the seal. Right? So we'll get back to that. See that? Cliffhanger. Angiotensin. So angiotensin 2, This is an interesting chemical, and it's one you're going to have to know too. So we'll get into it. It's a long pathway of chemicals, actually. But angiotensin, angio refers to blood vessels. What do you think it's doing to the blood vessels? Look at the name. Angiotension, right? Vaso, vessel pressure, angiotensin is the way you want to remember these two words. The whole goal of angiotensin, it has lots of purposes, but its main goal is to do what to your blood pressure? Increase it. So vasopressin and angiotensin, right here on this slide, you want to remember they're vasoconstrictors. What do they both do to your blood pressure as a result? Increase. What does everything so far do to your blood pressure? Increase it. If it's a vasoconstrictor, it increases the pressure. And the last one, cold. You can try this at home. Take an ice pack, put it on your arm for about 15 minutes. Pull it off. What color is your arm? White. Why? Because the cold temperature did what to those blood vessels? It constricted them. And then the second ones are exactly the opposite. So things that cause vasodilation you have to know. If an increase in that stretch activity cause vasoconstriction, what if you decrease that stretch? You decrease the myogenic activity. The muscle naturally relaxes. It opens up. So a decrease in vasogenic or muscle-generated activity causes relaxation. And I keep saying muscle-generated, but I'm referring specifically to smooth muscle here. Like the stomach situation that we talked about earlier. Sure. Cold, yeah. If they come in from outside, they're purely red.
Like your teeth get like
That's an interesting one. I don't know. Yeah. If I had to guess, if I had to take my physiology knowledge and put it together, I would guess that because you're cold, you're pushing all that heat into your core and up towards your head, and you just get that overflow to your face is what I would have to guess. But that's just shooting from physiology concepts. So I don't know technically why. Yeah, that's interesting. Your hands turn white, but your face turns red. Okay, next. I'm not too big to say I don't know. So, next one was decreased oxygen. Just the opposite of the last one. If you have a lack of oxygen in a muscle, what's that muscle want to do? It wants to dilate. Why? It's trying to increase blood flow. It's trying to push the flow in, right? So you're trying to increase the blood flow getting into the tissue. If you have lots of metabolic activity going on, you're burning oxygen, so you're running low on oxygen, you increase the flow. If you're burning lots of oxygen, you're making lots of CO2, carbon dioxide. Again, two sides of the same coin. Remember that endothelin? Most powerful vasoconstrictor? Nitric oxide is just the opposite. Nitric oxide is a powerful vasodilator. So powerful that back in the early 80s they came out with this drug for people that had heart problems. Because if your coronary circulation sucks, you know, if you're old and you have lots of plaques and everything and the blood vessels aren't expanding properly, they came up with this idea, if we give you this chemical that stimulates nitric oxide production, we should be able to open those coronary blood vessels up and increase the blood flow, right? So it should get more blood flow to the heart, which increases, you know, heart longevity. What they found is that when they started giving this pill, the studies showed that statistically it wasn't good enough. It wasn't causing enough change to justify making it into a regular drug to prescribe people for cardiovascular problems. So what was interesting though, when they started stopping it, these old men kept coming back in for more and more and more. Because for the first time in years, because their blood pressure was so bad and the blood circulation to special parts of their body wasn't working the way it used to, when they took this nitric oxide increaser, it went to the special areas and increased the blood flow, right? So what do we call that little blue pill now? Viagra, yeah. It will do the same thing, yeah. It does the same thing. The clitoris and the glans penis are actually like the same organ, just a different sex. And when we get to reproduction, we'll talk about that too. Because if you have overproduction of testosterone in little girls, it actually starts looking like a penis. It will actually extend out like a penis. And if you have underproduction of testosterone in a boy, it shrinks down, so it actually looks more like a clitoris. Yeah. So it's the same structures. Vascularly, they're the same. Like neurons in there, they're the same. They're extremely highly vascularized and highly, you know, neuron-filled tissues. But nitric oxide, powerful vasodilator, so you want to think Viagra, and it causes dilation, which increases blood flow to organs. All right, decrease, and it didn't work for those men because those, you know, the the people with the heart, because their blood vessels were so full of plaque and they were so hardened that it didn't matter anymore. That they weren't getting the stretch that they were trying to achieve.
They still use metronome outside of the
For pediatric would be a different situation because they haven't had they haven't had all that plaque and build up and all the crap that we abuse. So, yeah, I'm thanking McDonald's. Decrease sympathetic stimulation, so just the opposite. If you don't want that constriction, you just let off the accelerator and it slowly dilates. So when you're relaxing and resting, what happens to your sympathetic nervous system? It turns down. It just naturally turns down. It doesn't matter that your sympathetic went up. Not for here. Your parasympathetic goes up when you relax, but it's the sympathetic going down that you want to pay attention to because it is the one that has the focus on the blood vessels. All right, next, increased histamine. What was the chemical that was just the opposite of this? Epinephrine. Not vasopressin. Epinephrine and norepinephrine. Histamine is associated with what reaction? Allergic reactions. Yep. Histamine in small quantities is good for the local area, but when it gets into your system, it causes vasodilation, which is going to do what to your blood pressure? Drop it down, which could cause what? Anaphylactic shock, or shock in general, yeah. So if somebody gave you an injection of histamine, what did they just do to you? They just sent you into shock, basically, yeah. It's going to cause vasodilation everywhere. Your blood's going to race to your feet. You're not going to get enough blood flow to the heart, and you're going to end up dying. And then the last one, just the opposite. If you put a hot pack on your arm for 15 minutes, you pull it off, what color is just that patch? It's red. It's causing vasodilation in the area. That's why when you have increased inflammation in an area, what do you put on it? Ice, because it decreases blood flow and decreases that swelling. But the day after, when there's no swelling there, but the muscle's still sore, why do you put a hot pack on it? To increase the blood flow, so you're bringing in the healing factors, right?
Why is it
After a certain amount of time, it reverses, goes from constriction to dilation.
I don't know. I'll have to look that one up too. I've never held one on that long. I was always taught that you rotate them off, but I guess I.
chiropractors tell you if you have they tell you to use ice only, not heat.
I used to work for a chiropractor, and he said swelling was the enemy of, inflammation was the enemy of healing. It's over-inflammation. You want a little bit of swelling because you want the blood flow coming in, but when it's an extreme, then you want to take it away. I think I'm going to stop talking about chiropractors. Okay, and then these pictures are just showing the comparison. So here's a normal blood vessel, and then boom, vasoconstriction. Yep, and then vasodilation. And here you see all the factors listed right next to it, in case you like the picture. Okay, so local control of arterial radius. Local control is talking about the changes inside the tissue. The arterioles are the structures that take an artery's blood and go down into the actual specific tissue. So when you take an artery, it just gets you the blood flow to the area. When you go into the actual organs, the tissues themselves, then you have to use arterioles to constrict or dilate to regulate blood flow. So at the area, if you have active hyperemia, it means what's happening is that area is active and you actively increase your blood flow. What's emia mean? Yep, it's referring to the blood. So active hyperemia, when you have an active area of the body, you're trying to increase the flow to that area. If I just take my arm and I hold my whole body sitting on the couch and I just start doing bicep curls, what's going to happen to my arm compared to this arm? It's going to get more red, it's going to have more blood flow, it's going to actually have something called active hyperemia, an increased blood flow because of the use. Right? Local chemical influences, you already saw some of these. When it says local metabolic changes, what two gases do you want to associate with right away? Oxygen and carbon dioxide. Yep, so local metabolic changes. If I increase the CO2, what's going to happen to the blood vessel? Dilate. You have to think of it this way. If you have too much CO2 in an area, do you want it there? What's going to carry it away then? Blood. So you increase the blood flow and it takes it away. If I have too much oxygen in this organ, too much oxygen, right? If I have too much oxygen in this bicep, what's going to happen to the blood flow? It will decrease, causes vasoconstriction, because I'm not metabolically active. I'm not doing anything with the bicep, so it has too much oxygen, or plenty of oxygen, I guess is a better way to say it, so you decrease the blood flow. This is just the same thing we talked about in the last two slides. And then histamine release, what's histamine going to do locally? Causes dilation. It causes dilation to try and bring in things like white blood cells, clotting factors, neutrophils, like I said, white blood cells. So it's trying to bring in those things that are going to help you heal. Lots of sugars, lots of proteins, lots of nutrients, so you can repair that area.
But it's controlled.
It's controlled.
As opposed to resting or something like
right. So when it's localized, if I, like for instance, if I took histamine and put it on the tip of a pin, and I scratched the surface of your skin, but I didn't go down deep and actually penetrate into the blood vessels, if I just scratched the surface, you would have swelling in that area. You didn't bleed because I just hit the epithelium, but that histamine is stimulating all those little what cells? Mast cells, yep. Stimulating the mast cells, and it's also triggering more release. So histamine is actually a positive feedback loop because histamine causes release of more histamine. Does that make sense for positive feedback? Okay, and then local physical changes, so application of heat and cold, we already talked about that, and the myogenic response. So if you stretch a smooth muscle really quick, what's it want to do? Constrict back. If I slowly stretch it, what's it want to do? It wants to stretch. It wants to go ahead and relax and work with it. Okay, so extrinsic control of arterial radius. Extrinsic means it's outside of the blood vessel, remember? So two main systems are extrinsic controllers. Every time you see an extrinsic controller of a system, what two systems should pop in your mind? Nervous system and the endocrine system. First day of class, talked about the two controllers of the rest of the body. Nervous is fast and precise. Endocrine is loosey-goosey. It's slower. It's less precise. It sticks around longer. Sympathetic, right? Except when it's the brain. Why is it not extrinsic when it's the brain? Because the brain is controlling the brain. What is that called? It's called intrinsic. Yeah. And then cardiovascular control center is where? Do you remember? What's the part of the brain that's responsible for those life-important functions like breathing, heart rate, choking, gagging, sneezing? What part of the brainstem? Medulla oblongata. Yep. So the cardiovascular control center is in the medulla oblongata. What happens if your medulla oblongata stops suddenly? Does your heart stop suddenly? No, the heart can keep going. This is just a regulator. It's an extrinsic controller. As long as you keep providing oxygen to that person's body, their heart will keep beating. All right, hormonal influences, vasopressin. What's it going to do to your blood pressure? Increase it, so what's it do to the vessel size? Constricts. How about angiotensin? Oops, did I say that wrong? It causes vasoconstriction. Yep, causing blood pressure to go up. And then epinephrine does what? Causes vasoconstriction. Hat trick, all three of them. So epinephrine also causes vasoconstriction, causing your blood pressure to go up. So if you like flow charts, here are all the different things that we've talked about. The myogenic response, the heat cold, the histamine, the local changes in gases like O2 and CO2. Sympathetic stimulation, there's your epinephrine, angiotensin, and vasopressin too. So when you look at the locals, they go in this pathway, the extrinsics go in the other pathway. Nervous system, endocrine system. These are all within the smooth muscle itself. When you look at the arterial radius, when you're changing that, that has a direct effect on the total resistance of the body. When you see this abbreviation TPR, it means total peripheral resistance. When you see MAP, what's it stand for? Mean arterial pressure. The total peripheral resistance is the resistance. Guess what equation I'm working on here? Total peripheral resistance, mean arterial pressure. If you take the pressure and the resistance and you put them in that little math equation, what are they determining? Your flow. They determine your flow. Right? So when you talked about local size of vasodilation or vasoconstriction, that's local size. When you look at the whole body, you have the mean arterial pressure, which is the average pressure throughout the body. The total peripheral resistance is the average pressure throughout the body, or resistance throughout the body. The average of everything is what the body determines. The body doesn't look at specifically one organ and say, oh, that poor organ, let's take care of it. The body says, what's the greater good for the whole body? It looks at mean arterial pressure. It doesn't give a damn about systolic or diastolic pressure. You do. It doesn't. It looks at MAP. It doesn't look at one area's blood pressure. It looks at the whole thing. Right? So when we look at the arterial radius, we also look at things like viscosity. That influences resistance. What's the other thing that would influence the resistance? The total resistance. The length. Yep. So the only thing missing off this flow chart is the length. Now you have all the factors for resistance, but this is as a whole body now instead of one location. So blood viscosity, the number of red blood cells, the concentration of the plasma proteins. So the more proteins you have in makes it thicker. The more blood cells you have in makes it thicker. If I took something away, what would make it thicker? If I took away water, right? So if I took away water, it would also make your blood thicker if I dehydrated you. Sometimes just think a little bit extra. Think of what else would actually cause this. Was it this class or the evening class I was talking about that? My wife and her doctor. That was, yeah, you have to think globally in medicine. You can't just think memorize this one thing and everything's perfect. You have to think of what the effect overall is going to be. Okay, so flow equals change in pressure resistance. I already told you that's where I was heading to. So the next thing we can do is remember that cardiac output. We can actually calculate cardiac output in another way. We can look at cardiac output as a form of flow. Cardiac output is talking about flow per minute, right? So I can use the same equation. Flow equals pressure divided by resistance. Look what I did. Cardiac output equals mean arterial pressure divided by total peripheral resistance. You can use exactly the same equation that we used up here. I told you that equation would be important. We keep coming back to it. So we use this one for one single vessel. We use this for the whole body. This is what your body monitors. You have little tiny receptors that are detecting pressure. And then I mentioned this earlier too. So the arterioles are the only ones that are regulated intensely because that's what's determining the flow or the cardiac output to each of the organs. What vessels would be controlling pressure overall? The arteries. When we talk about the resistance, we're talking about arterioles. Yep. So if a patient had a blood pressure of 135/90 and their TPR is 3, could you figure out their cardiac output? You could. What equation are you going to have? That cardiac output is equal to blank. What's the blank? Mean arterial pressure divided by total peripheral resistance. But they didn't give us mean arterial pressure. So are we lost on this one? You can figure it out. We actually did this earlier, remember? Before we said 135 minus 90 is 45, which gave me a pulse pressure divided by 3, which is 15, plus diastolic gives me my mean arterial pressure of 105. So what was the answer here? 105 divided by 3 is about 35. Yep, so the right answer is 35. Next blood vessels, the capillaries. Nickname, exchange vessels. So these are the site of exchange. They're the exchange vessels. The arteries are too thick. You can't get diffusion there. The arterioles are still too thick. There's lots of smooth muscle. You can't get diffusion there. In fact, what's interesting about the arteries are that you have, anybody remember the name of the little vessels that supply blood to the actual arteries? The vasa vasorum. Anybody remember that term? It means vessels to the vessels. It's an interesting term because the arteries are so thick, all that blood flowing through them is not getting into the wall of the artery. It has that Teflon coating. So it actually has an alternate arteriole that comes out to circulate to the muscle of the artery. It's crazy. It's amazing how complex your body's design is. But you can't get diffusion across the artery wall. Can you get diffusion across the arterial wall? Nope. So even those arteries, when they break down to arterioles, have to break down to a capillary. And that's where you get the exchange. Because capillaries are how many cells thick? They're one. They're one cell thick. Remember, they're like little shingles. You just put them and bump them up next to each other. They have leaks in between them, right? So fluids can leak out like water. Nutrients can leak out like glucose. Gases can exchange across like carbon dioxide, oxygen. So these are perfect for exchange because, according to whose laws? Fix. A thinner membrane means faster diffusion. Yep. So a thinner membrane, faster diffusion. We only have one cell wall. Well, two if you're going all the way through the cell from one side to the other. But easy diffusion. What's going to diffuse the easiest, by the way? Water-loving substances or lipid-loving substances? Oh man, the lipids are going everywhere, right? Luckily for those water-loving things, you have these little tiny pores that you can squeeze through. So ideal site for diffusion because there's a large surface area. This may seem counterintuitive. When you look at an artery like the aorta, this thing's like an inch across, right? You can visibly see it with your eye. Can you see a capillary with your eye? Nope. Arterioles and capillaries are called microcirculation because you can't see them with the naked eye. If you see a vessel, it's got to be either a vein or an artery because with your naked eye. These things are so teeny tiny. But when you think about it, you have one aorta. How many capillaries do you have? Billions, right? So you have billions of capillaries. So overall, their total surface area is immense compared to this one little tiny aorta. The second is the thin capillary wall, which I just mentioned. So you have to think big picture here. Overall, there's a larger surface area. When we get into the airway, we'll talk about the same thing. Alveoli, they're teeny tiny little guys. But when you put a million of them together, they make a huge surface area. Same concept. And this comes back to whose laws again? Fix. Right, so slow velocity through the capillaries. The velocity is referring to what? Speed. The flow coming out of the heart, whoosh, you gush the blood out. High pressure, high speed, that's why they call it rapid ejection. But as it's breaking down and bifurcating, or bifurcating depending on where you're at, as it splits from an artery to the arterioles to the capillaries, you're getting more and more. What's happening to the speed? Slowing down. It's like having a gigantic river that branches off into a small stream and then down to a tiny creek. How fast does water flow through a creek? Slow. But in a river, man, if you get close to the center, what happens? It'll suck you under, right? You get that undertow. I grew up down by the river, so I can always compare those things. Okay, and actually I did. I think I've referred to the creek before. But in the creek, you can stand in the creek and it feels good having the water flow over. But if you're out in the middle of the river, whoosh, sucks you under. Right? So water-filled pores in the capillary wall is the next thing. And those water-filled pores let water-loving substance pass through. Can water-loving substance squeeze through the cell wall? No. So what it does is it goes through the pores. Remember, you've got, like I'm holding with my fingers here, they're woven in between each other. And you can see these little tiny pores for water-loving substances. What happened to those pores in the brain? What do you call that barrier? Yep, the blood-brain barrier. What cells did this? Astrocytes smashed those pores together so that do water-loving substances easily leak into the brain tissue? No. But in all of your other tissues, you've got these big pores so that water-loving substances can leak back and forth. I just realized I had the spotlights on me. I looked down and I felt like, oh, like there was a glow. Is that you, God? All right. And the metarterioles and precapillary sphincters. So these are other structures. These are important structures, though. The metarterioles are the transition structures that go from an arteriole into a capillary. They're not considered their own actual blood vessel, but they're like the transition way. They look like this. Nuts. They look like this. So here's your arteriole. Here you have that branch coming off. This is the metarteriole. And then here are your capillaries. So what's kind of cool about these metarterioles is they have special little structures that are called precapillary sphincters. These precapillary sphincters are smooth muscle, but they are not controlled by the nervous system. There's no nerve coming up to the precapillary sphincters. The precapillary sphincters are completely controlled by metabolism. And this is how it works. So you have an artery that branches to an arteriole. The arteriole branches into this little metarteriole, which is a transition way into the capillaries. Here's what we refer to as the capillary bed. So you have all these capillaries. It's like a sheet or net going off every one of your tissues. When the circulation comes down here, you can see the flow can go straight through into a venule and then off to a vein and back to the heart. If I don't need circulation in this capillary bed, guess what this smooth muscle does? Constricts. So if there's no metabolism happening here, what happens to my oxygen level here? If there's no metabolism, what happens to the oxygen level here? It stays high. What do you know when the oxygen is high, what's going to happen to smooth muscle? It constricts, right? If I'm not burning oxygen, what am I not making?
CO2.
I'm not making CO2, right? I'm not making ATP, but you're right there too. It's not making CO2. So I have low CO2 and high oxygen. What do you know about the smooth muscle? It will be constricted. What's happening to the flow through here? It's slowing down. I don't need the flow here. So the blood vessel will actually push straight through and bypass that capillary bed. So these met arterioles are really cool because they actually let you bypass a capillary bed when you don't need flow there. But let's say this bicep, I start working this bicep. What happens to my oxygen use here? It goes up. So what happens to my oxygen level? It goes down. What happens to my carbon dioxide level though? It goes up. So what's going to happen to this little piece of smooth muscle? It's going to open up and let blood flow go into this capillary bed. Does that make sense? What did I tell you does not control this? It's not controlled by the sympathetic nervous system. When we looked at the arterioles, they're controlled by the sympathetic nervous system, but not the met arterioles, not the precapillary sphincters. They're specifically controlled by metabolism exclusively. If you're using this muscle, it will open up the blood vessels to get more oxygen in and clear more CO2 out. If you're not using it, it will crimp down the blood vessels so you can bypass them. You want to make sure, if you just clipped off all of these arterioles, the blood would get backed up in the arteriole here. So if you crimped off all the metarterioles, the blood would get backed up. You can't do that. You have to let the blood flow through to the venules so it can go over to other tissues or back to the heart. Right? So here are all the main points again. When I talked about overall surface area, when you look at the aorta, you can see the speed, the velocity, 500 millimeters per second. So that's 50 centimeters, that's about 20 inches. It goes about this far. Every second is how far the blood goes. That far in a second. In the aorta, look at the capillaries though. It goes 1/2 of 1 millimeter a second. That slow. Why that slow? Because it needs time for diffusion. It's trying to drop off what into the tissues? Oxygen. It needs time for that oxygen to get out, get into the tissues, and pick up what? CO2 and waste products and carry them away. So it moves really slow through the capillaries so you get time for exchange. The slower the movement, the faster the rate of diffusion. Right? When you look at the actual anatomical distribution, here's the aorta, but look at all those capillary beds. So when you look at the total surface area, here you have 4.5 centimeters, squared centimeters, square surface area. And over here you have, in the capillaries, 6,000 square centimeters. So math-wise, what is that? About 1,500 times more? Something like that. So 1,500 times more surface area in the capillaries than you do in the aorta. What's that give you a chance to do? Yep, higher surface area, greater diffusion. But look at the flow. This is a tough one to understand. The flow all the way through. In the aorta, the flow is the same as it is in the capillary all the way into the venules. Why is the flow the same? Because what moves into one area has to move to the next area. You have the same flow, but what do you do to the speed of flow? Yeah, you can adjust the speed. You can slow it down for the capillaries and you can speed it up in the aorta so that the flow stays the same. It's the flow you're trying to regulate, and what two factors regulate your flow? Pressure and resistance, and you can break that down into things like radius and viscosity and all that. So we're coming back to that same concept again. The flow has to stay consistent. So if I raise the resistance in an area, what do I have to do to the pressure? I have to raise the pressure to try and keep the flow the same. If I raise the resistance but I don't change the pressure, what happened to my flow? I just cut the flow off, right? Yeah.
Did you say it was the meta-arterioles or the precapillary sphincters that are
The precapillary sphincters, which are surrounding the meta-arterioles. So the precapillary sphincter is a structure. It's the smooth muscle that wraps around the meta-arteriole. Does that help?
Yeah.
Right. And then here's an example. You can see this volume of water. As you move from one type of vessel like this, it just spreads out. The flow is exactly the same. And then when you come back to the smaller vessel again, the flow is the same. So here you have an artery. Here you have that spread of capillaries, large surface area. And then here you have that small vein again. So the flow will be the same all the way through. It's the rate that changes. So where's the rate going to be the highest? In the river or in the lake? Where do you get faster flow?
river.
River. If you have a big lake, there is actually movement of water in the lake. It swirls around, it moves around, especially if you have a river here and a river here. But it just feels like it doesn't move. I think if you go to Sailorville Lake, you can actually experience that, right? Because there's like a large river area that comes into it, and you can feel the flow. If you put your feet in the water, you can feel it flowing over. But just go down to the lake area and put your feet in. It feels like it's still. It's moving so slow. But there's also a river going out of the lake, too. Right? Here you have the example of the blood vessels. I used my fingers as an example before. But you have those, each individual epithelial cell, they squeeze together so they form this barrier, but they have the little tiny leaky pores, like in between my fingers here, that water can leak in and out. Anything that loves water can leak in and out. Okay? Small particles like oxygen and carbon dioxide, they diffuse right through the cells. They don't need a pathway. Something large like glucose needs to leak through here. It's a large piece of sugar. It has to leak. So does glucose easily get in your brain? No. Glucose actually has to be, what method do you have to use to move it across the membrane? What do they call that? Transport. You have to have transport mechanisms to move it across the membrane to get it in the brain. You don't need that in the other tissues. Okay? It's because of these leaky pores. So here are some examples. Like I said, the oxygen and the CO2 can just go right through the endothelial cell. If it's a plasma protein, it's a big, bulky, fat protein. These things are like spaghetti strainers. You've got little tiny holes. Plasma proteins are like rice. Does the rice go through the spaghetti strainer? I disagree. I disagree completely. It doesn't go through the spaghetti strainer.
Depends on the angle of the rice.
Yeah, it depends on the angle. So if you throw your rice just perfectly, then it will go through probably. But yeah. But you have a good point. Do some of the rice pieces manage to find their way through? A couple rice pieces. If you put 1 million rice pieces in, you're going to have like 100 that slide through, right? It's the same thing here. We're going to talk about that concept later. Some plasma proteins will actually leak through. They leak through, but they cause problems, and I'll show you where those problems are. All right. Anything else like that glucose, you have to exchange it across by a what? A carrier, a transporter. Yep. And then things that are charged. The things that are charged, like sodium, potassium, leak right through a cell membrane. Nope, we talked about this in a neuron. You have to actually have pores or carriers to move these things. But can they leak through a giant pore? Yeah, they can leak through pore. I just said it, didn't I? But they can't leak through one of those water pores. So they can slide right along with the water through those water pores. Little tiny amino acids can slide through here too. What are proteins made out of? Long chains of amino acids. There's a difference between an amino acid and a protein though. Amino acids like saying this room, a protein's like saying the whole building. It takes rooms to make a building. So amino acids are little tiny areas that can squeeze through, but the proteins are just too big to get through. And then this must be important since I put a star on it. So plasma proteins don't cross, but oxygen and CO2 can actually passively diffuse right across the membranes. Okay, and then there's that example again with the precapillary sphincters, the metaarterioles, and you can see these little precapillary sphincters, they're wrapping all around so that if there's an increase in metabolism, what can they do? Relax or constrict? Increased metabolism. If they constrict, what's it do to the blood vessel? Squeezes it. Do you want that? Increased metabolism, you want it to relax and open up and dilate. Is the nervous system controlling that? Nope. Oh, look, no nervous supply or smooth muscle on the capillaries. So no nervous supply or smooth muscle on the capillaries. Capillaries are one endothelial cell, one epithelial cell thick. There's no muscle around them. No smooth muscle. So can you constrict a capillary? Nope. Can you actually dilate a capillary? No. What histamine does is histamine makes those cells, the endothelial cells, retract is what it's called. They kind of spread out a little bit. So they open up the pores. What happens? When they open the pores, and they make the pore holes bigger, what happens? More fluids leak out, right? Which causes what in that area? Swelling, right? It causes edema in that area. It's not dilating. The capillaries don't dilate. They call it retracting, where they shift a little bit so that the pores open up. And we'll talk about that concept too. Okay, so the degree of resistance of arterioles in the organ controlled by the sympathetic activity. This is the organ itself. The organ determines how much flow it gets. It can be manipulated by the sympathetic activity, so would that be extrinsic or intrinsic? What would the local factors be? Intrinsic. So sympathetic is extrinsic, local factor is intrinsic. And then the number of open capillaries are controlled by what little things? The precapillary sphincter. They determine how much of this capillary bed is getting flow or circulation. So the arterioles bring the blood into the actual organ, but into the capillary bed, it's those precapillary sphincters that decide what's going on. Right. So if I look at metabolic activity, you know what's happening with oxygen and CO2. If I'm metabolizing, I'm burning energy, what happens to O2 levels? They drop. What happens to your CO2? You're making a big pile of it. Right? So if I decrease the oxygen, what do you know about the blood vessels at the arterioles? They dilate. They're bringing more blood flow in. What's going to happen to those little precapillary sphincters? They open up also. So overall, I'm increasing the blood flow into the organ and also into the what? Capillary beds. Exactly. So what am I doing to the rate of diffusion when I'm bringing more blood flow in? I'm increasing the diffusion. So what's going to happen to my oxygen level as a result? It's going to go back up. What's going to happen to my CO2 level? It's going to go back down because the CO2 diffuses out of the tissue into the blood and it gets carried right away. So if I increase the flow, I can take away waste products faster. That's why you put, like a warm pack onto an area that you want to increase healing because you're increasing the flow going through. Next, exchange between blood and the surrounding tissues accompanied by bulk flow and passive diffusion, or accomplished by bulk flow and passive diffusion. Bulk flow is exactly that. It's taking lots of particles and moving them across the membrane. It's taking and distributing it across from one extracellular fluid compartment to the other. And we talked briefly about extracellular fluid compartments like the first week of class. I talked about the extracellular fluid as everything that's outside of a cell. So inside the cells where you have high potassium, you have the nucleus of the cell, the cytoplasm, all that stuff, that's intracellular. Everything else outside is extracellular. So what would the space between the cells be called? Intra or extra? Extracellular. What about the stuff in your joints, that synovial fluid? Extracellular. What about the stuff in your eyeball? Extracellular. What about the plasma in your blood? Extracellular. It's all extracellular except what's literally inside of a cell. So bulk flow, if I'm talking about the intracellular, the space between these cells, and I'm talking about the plasma, that's exchange between the extracellular fluids. I put glucose in my blood, where do I want to get it to? Do I just want to keep it in the blood? I want to get to the interstitial fluid, the space between the cells, and eventually get it into the cells themselves. So I can take bulk flow, move something from the plasma down into the interstitial fluid until it goes to what? Equilibrium. So if I'm running low on sugar between the cells because the cells are burning lots of sugar, what's going to happen? I'm going to bring more sugar into that space because it's moving down its concentration gradient, right? As I'm burning that, I'm building up CO2 in the interstitial space. What's it going to do? It's going to diffuse into the plasma to carry it off to the lungs, right? So it's moving down its concentration to carry it away. So when I have this ECF distribution, I mean between the different ECF compartments, whether it's interstitial between the cells or the plasma, we're going to shift fluids and contents back and forth always. If I deprive your blood of oxygen, what's going to happen to the interstitial space? What am I going to do to the rate of movement? Speed it up going into the interstitial space or slow it down? I'm going to slow it down. What's it going to do to the movement of oxygen from the interstitial space into the cell? Slow it down too. What's going to eventually happen to the cell? It's going to starve and die, right? And then passive diffusion is how you exchange different things like the solutes. So, here's the little picture. What do you call this space in here? By the way, what is that dark thing? It's a nucleus. What do you call this space in here? Intracellular, within the cell. What do you call the space between? It's extracellular, and specifically it's what? Literally means space between. Interstitial. Yep. So what's this? Also extracellular fluid, right? What is it? What is it in the vessels that's the extracellular fluid? It's the plasma, right? So it's the plasma in the blood. This is all extracellular fluid. It's just two separate compartments. So keep that in mind when we're talking about extracellular fluids. It's not just one fluid. It's all these fluids that is not in the cell. Here's how your diffusion works. So if I have a lot of sugar in my blood, very little in the cell, if it's low in the cell and medium here in the interstitial space, where does it go? It wants to go in the cell. It has a little transporter and brings it into the cell. If this is medium and in my blood it's high, where does it go? it goes from the blood in here. So it creates this flow moving downstream, high concentration to low. You always have to compare where it's going. If I have high oxygen in my blood, low, lower in the interstitial, where does it go? In the interstitial. If it's in the middle here in the interstitial, but really low inside the cell because the cell is metabolizing, where does it go? In the cell. Remember, the cell is metabolizing, so it's burning glucose and oxygen and making what? CO2. So it's making CO2, and now the CO2 is building up a lot, right? Where's the CO2 want to go? Yep, if it's high concentration here and medium here, it goes out of the cell. If it's medium here and low in the blood, it goes into the blood. What about water? I'm making lots of water. If I just kept making water in the cell, what would it do? It would explode eventually. So now I have high water concentration in the cell. What's it want to do? It wants to diffuse out. It goes through those little aquaporins, those water structures. It goes to the interstitial. But now the interstitial fluid's filling up with water. That's going to cause edema. Do I want that? So where do I push it? Back into the cell? I push it into the low volume in the blood. And if the blood starts filling up, guess where the blood pushes it? To the kidney. Right. So always think there's some kind of pathway. If you're getting way too much water in your body, your kidney is going to start clearing water out of the plasma to make room for that extra water. Anybody think of another way you get rid of water out of your body besides sweat? You start exercising, how do dogs get rid of all the extra water and heat? Yeah, you can actually blow it out too. So there are a lot of ways. We'll talk about that when we talk about water concentrations, electrolytes. Right? So remember the movement. We've talked about this concept before, diffusion moving downstream. Right? Next, capillary wall is like a sieve. Think of it like a filter. Fancy word for a spaghetti strainer. But in the kitchen, it's called a colander. Right? So capillary wall is like a sieve or a filter or spaghetti strainer, whatever you want to think of it, with pressure on the inside and on the outside. But the change in the pressure is going to affect where the movement of things are. So if I were trying to dump spaghetti into a spaghetti strainer, but I put a fire hose on the bottom of the spaghetti strainer and cranked up the pressure down there, what's going to happen? It's going to go up through the spaghetti strainer. No water from the spaghetti is going to go down. It's going to go flying up through the air, right? So you can change or manipulate the pressure on the different sides of this filter and affect what's going on. Right? So actually, before we move on, ultrafiltration reabsorption. Here's a thing that I've learned about everything in science/medicine stuff. When you're looking at the blood is usually your baseline control center for the body. Because when you want to know what's going on inside the person's cells, what do you take a sample of? You just rip a piece of tissue out of the body? First thing they want to do is they want to take a blood sample, right? They want to take a blood sample and they want to look at what's happening in the blood. Because if you look at what's happening in the blood, you can kind of determine what's happening in the cells. When you're looking at different pressures, when you're looking at the movement of things, the blood is always your reference point. If they don't say what the reference point is, just assume it's the what? It's the blood. When we talk about filtering something, we're saying we're filtering it from the blood. Just as a thing that should pop in your head. If you're trying to reabsorb something, we're trying to reabsorb it into the blood. No, I'm saying, think about it, yeah. I should not point at my head. So think of it as your reference point. If you're filtering from the blood. If you're reabsorbing it into the blood. Right? So in this part, I don't remember what your book wants you to do, but this is an arbitrary assignment of a value, and I'm going to tell you what you need to know. When you filter, put a minus sign by it. Anytime you see somebody talking about filtering, that means you're removing something, right? You're filtering something, you're removing it. Plus or minus wants to pop in your mind when you remove things. Minus. So anytime you see any kind of a value that refers to filtration or removal from the blood, you want to think it's subtracting, right? When you see reabsorption, you're doing what? You're adding it back to the blood. So it's an addition sign. You're contributing to, you're bringing back into, you're adding it to the blood. So when you see that filtration or reabsorption, it's always referring to the blood if they don't tell you otherwise. Okay? So when you alter filtration, it's alter referring to teeny tiny. You're filtering from where to where? From the blood, right? Because we already said it's coming out of the blood, and you're going into the, somebody just said it, into the interstitial fluid, into the tissue, right? So it's going out of the blood, you're taking it away from the blood and putting it into the next extracellular fluid, which is the interstitial, which is inside the tissues. If you're reabsorbing, you're sucking it out of the tissue and you're adding it to the blood. When you push fluid, when you push blood into a tissue, what if I just always pushed blood into the tissue and never brought it back out? What would happen? Tissue would keep expanding. What do they call that? Edema, right? So when you push blood into a tissue, you also have to pull it back out of the tissue and put it back into the blood circulation. These are the 4 pressures you need to watch for. So these are the 4 factors that influence things moving back and forth across the capillary. So these are the 4 factors that are influencing filtering and reabsorbing. First one's capillary blood pressure. This is like the pressure from your heart pushing. It's pushing all this fluid into your blood vessel, but what's happening? If I start pushing lots of blood into the vessel from the heart, where does it want to push the blood now, or the fluids? It wants to push it out of the capillaries and into the tissues. So the capillary blood pressure is the pressure created by the heart that's trying to squeeze water out of the capillaries. I push it all the way downstream. I'm pushing it really hard. I've got these leaky capillaries. So if my heart beats harder, what happens to the leak? It leaks faster, right? Think of a sprinkler out in your backyard. If I turn up the opening, I turn up the valve, what happens to the flow out of the sprinkler? It goes up. Your capillaries are exactly like sprinklers. You've got this tube with little tiny holes in it, right? You turn up the flow, you turn up the heartbeat, you're going to push more pressure, forcing fluid out of those capillaries. So would that be a reabsorption or a filtration process? It's filtering. It's filtering water out of the blood, right? So it's pushing the water out into the tissues. What value do you want to put by capillary blood pressure? Negative. You're just taking it away. Exactly. You're taking the water out of the blood. It's a negative. It's a filtration. Next one's fluid colloid osmotic pressure. Big words. So the blood colloids, colloid's a fancy word referring to protein-like substances. So you can think proteins. The more proteins I have in the blood, the higher the colloid osmotic pressure. Proteins are a solute. What do they want to do to water? Push it away or pull it towards? Pull it towards. So if I have more proteins in my blood, what's it want to do to the water? Push the water out of my blood or pull it back into my blood? It wants to pull it back into the blood. It's sucking water from your tissues into the blood. The higher the solute in the blood, it's more hyperosmotic. What's it going to do to your cells and your tissues? Hyper shrinks them, right? So it's going to start shrinking. Why is it shrinking them? Because it's sucking the water into the blood, right? It's adding it to the blood. What sign should you think of? A plus. The more proteins I have in my blood, what's it doing to my tissues? It's dehydrating my tissues. It's pulling more water out of my tissues. Don't think salt here. No. Here just think blood colloid osmotics. Think just like proteins, blood cells, just solutes in general. Yeah. Colloids usually are pointing at the proteins because we're going to come back to colloids later with proteins and really beat them to death. So what sign was that? Plus. Next one, interstitial fluid hydrostatic pressure. This is the interstitial fluid trying to stop water. How do I know it's trying to stop water? What's the word? Hydrostatic means water stopping. So this is the pressure. Let's say the tissue's filling up with water. I have a water balloon and it's filling more and more with water. Is it going to like it? No. That pressure is getting so great it's going to try and push the water back into my garden hose, right? If I'm filling up the water balloon, you're not going to see that because the garden hose is such high pressure. But if I try and push that pressure into the water balloon, eventually the water balloon is trying to push back. It's trying to push it back into the vessel. What would that be doing? Filtering or reabsorbing? It's trying to reabsorb it, right? It's trying to push the fluid out of the interstitial fluid and back into the blood. It's saying, man, my tissue's swollen and it's going to burst if I don't do something about it. So it's trying to push it back into the blood. You always have your atmospheric pressure. The atmosphere is squeezing on you right now, whether you realize it or not. It's squeezing, and it's squeezing down your skin, and it's trying to compress your skin to push the fluid back into your blood. If you went into outer space and you went out into space and jumped out on the moon with no spacesuit on, guess what happens to you? There's no pressure holding you together, right? So all that fluid comes out of your blood, it starts filling up your tissues, and it starts expanding the tissues, and you'll just... Bloop. Maybe not as fast as you see in the movies, but yeah. Your eyeballs would burst, your capillaries would start bursting. It'd be an awesome sight. So interstitial fluid hydrostatic pressure trying to push into the blood. Is that a minus or a plus sign? It's a plus sign. And then the last one, interstitial fluid colloid osmotic pressure. That's the interstitial fluid's proteins. You shouldn't have many of those. But if you have proteins in the interstitial fluid, what's it want to do to water? Does it want to push it into the blood or pull it into the fluid? It wants to pull it into the interstitial fluid. What's it doing? Is it adding or subtracting from the blood? It's subtracting from the blood. It's pulling it out of the blood. So how many pluses do you have here? How many minuses? 2. You have 2 pressures that are trying to push into the blood and 2 pressures trying to move out of the blood. Here's where the fun part comes. Now you'll have to be able to calculate. So you have 2 outward pressures and you have 2 inward pressures. If it's an outward, what sign did it get? It's trying to push out of the blood. It gets a negative sign. It's trying to steal it from the blood, right? Take it away from the blood. An inward pressure is trying to push it into the blood. When we refer to net exchange, you have to take the outward pressures and the inward pressures and stick them together. So all you have to do is if you assign a plus and a minus, just stack those suckers, right? So you have 4 numbers. You'll have 2 of them with minus signs and 2 of them with plus signs. You just do the math. You don't even have to write this equation out. You just go right straight down through the list. Right? Here's where it applies. If this is one capillary right here, this is the capillary specifically. Here's the heart side. Would I expect high or low pressure over here? High. So my capillary blood pressure that I was talking about here, the capillary blood pressure, is that going to be trying to push into or out of the blood? Out. What value does it get? A negative. So if I have 37 millimeters of mercury in pressure going whoosh, 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 every time trying to push out, it's trying to subtract 37. Okay. I have to have a pressure pulling in too. So I have a pressure pulling in. This little pi sign in your book refers to the colloid. So the colloid pressure. Here you have the colloid trying to suck the water back in. Is that a plus or a minus? It's a plus. If I just stick those 2 numbers together, I have a minus 37 and a plus 25. What's my value so far? I have a minus 12. So overall, what's winning? Reabsorption or filtration? Filtration. Is that a good thing? So on the heart side, with all this fresh oxygen, all this fresh glucose, all this fresh nutrients, is it good that I'm pushing things out of the blood vessels? Yes, because what I'm trying to do, I'm trying to nurture the cells that are out here, right? So I'm trying to push that stuff out. It's good to have an overall filtration on the heart side of the blood vessel. What do you want to have on the venule side? You want reabsorption. What are you trying to reabsorb back into the blood? Oxygen? CO2. You're trying to pull that bad CO2, the bad lactic acid. You're trying to pull the bad things out of the tissue, take it to the blood so that you can send it over to the kidney and the liver and get it processed. Does that make sense? So if I look over here, what should I come out with overall as my overall value? I should come out with a positive because I'm adding to the blood. So here's my blood pressure. Whoa, look at that change. Why did it change? Because when you go from an arterial or an artery down to a venule, you know what happens to the pressure. It goes down lower. The further away you get from the heart in this pathway, the lower the pressure. So over here I only have 17. Is that positive or negative? It's negative. It's trying to push out, right? And I still have 25. Why is it still 25? What did I say these things were? Primarily the proteins, right? So did I get proteins leaving the capillaries? No, because those little pores are too small, right? Remember? When I talked about those little pores, proteins shouldn't slide across. So should the proteins have changed at the capillaries? No, they're consistent. So now I'm adding 25 millimeter mercury and I'm subtracting 17. What's my overall pressure now? Positive 8 in this situation. So I have positive 25 minus 17, that's a positive 8 overall. Positive means what's happening. Is it going into the blood or into the tissue? It's going into the blood. That's the main thing you want to look at. These other 2 pressures shouldn't change, but you can add them in. So this pressure, this hydrostatic pressure, the interstitial hydrostatic pressure, that's my atmosphere. Am I going to get a lot of change in the atmosphere? No. Not unless I take a rocket ship and blast my butt up out of space, right? Then there's a big change. But this is going to stay consistent. So we can just assign this a 1, or negligible. And then over here, proteins in the interstitial fluid, should you have them? No. In a normal person, you shouldn't have those loose proteins in the interstitial fluid because they stay in the actual capillaries. The only time you're going to change these two numbers is in some kind of a disease state. So let's look at this. In this situation, I'm pushing nutrients out here. In this situation, I'm pulling things back into the blood. Did I get a perfect exchange overall? Positive or negative 11 and positive 9? No, there's a little imbalance. Which one's losing? I have more going out than I have coming in. You have to have a backup route. That's what the lymphatics are for. The lymphatics collect anything extra that you didn't pick up in the capillaries and takes it back into the circulation. So your book walks you through how you can calculate this the book's way. I'm telling you the easiest way, assign the positives and negatives and just pile them up. So if this value is a negative because it's taking out, this one's a positive going in, and I throw in these two, would this be a positive or a negative value? Positive because it's adding into the blood, would this be a negative? This would be a negative because it's taking out of the blood. But is there anything there? Nothing. But you look at all four of these values at any site along the blood vessels. So I have a negative 37, I have a positive 26, so overall that's a what? Negative 11. So my overall filtration pressure here at the site is negative 11. Looking towards filtration. What you're trying to do is that you're going to have high filtration on the on the heart side. As you get to the capillaries, you're going to actually hit what at this point? Equilibrium. There's no greater exchange here. There's no inward pressure overall or outward pressure overall. It's like nice and even. And then as we get back to the venule, I'm going to start shifting it over. So the rule of bulk flow is that you're constantly distributing back and forth between the extracellular fluid and the plasma. So interstitial and plasma. So think about this. If I had plasma reduction, if I had a hemorrhage, which side's losing pressure? The interstitial or the blood? The blood. If I'm hemorrhaging, what's happening to my proteins? I'm losing them, right? I'm losing proteins. So I'm losing all kinds of things. Overall, my blood pressure is dropping in my blood. What pressure is going to be higher now? The blood or the interstitial? The interstitial. What's going to happen? I'm going to start pushing more fluid into the blood to try and do what? Recuperate my volume so I can do what to my blood pressure? Bring it back up. And then there are other methods too. I'll start drinking lots of water. So I'll start drinking water. Why do I want to drink water? Because I'm trying to put the water into my GI tract, which will diffuse into my blood, because the GI tract, the tissues that make up the GI tract are still interstitial, right? The space in between those cells. So I move it from the GI tract to the interstitial fluid and into the blood. I'm trying to regain that blood volume again. What's going to happen to my urine production? Oh, go ahead.
What's the result of edema? It's being pushed into the interstitial fluid, right? Is it generally all over your body?
It depends on where it's at. Yeah, so you can have systemic edema, you can have pulmonary edema, you can have just like edema in one organ, or you can have, cerebral edema even. Edema, and we'll talk about that. There's actually a slide for edema. Okay, and I'm going to fix this right now. I can't believe I always forget to do this, but I'm going to get rid of these little signs. I don't even want you looking at it. I want you to figure this stuff out. All right. So what's the net filtration pressure if the CBP, what did CBP stand for? Capillary blood pressure is 28, so that's the pressure on the heart side. If the IFHP is 5, so interstitial fluid hydrostatic pressure is 5, and then the blood colloid osmotic pressure is 20, and the interstitial fluid colloid osmotic pressure is 2. Positive or negative for the capillary blood pressure? It's negative. It's trying to push fluid out, right? So I have a negative 28. IFHP is 5. What's that trying to do? That's the pressure trying to push back into the blood, right? So that's a positive. What about blood colloid osmotic pressure? That's also going to be positive. It's trying to suck water in. So I've got 25 positives, 28 negatives. So far I'm at a what? I have a negative 3. And then IFCOP is 2. What's that doing? That one's negative. So what's my overall negative? Negative 5. What does negative tell me? Is it adding to the blood or taking out of the blood? It's taking it out of the blood. What's that process called? I'm filtering the blood. So what's the right answer? Number 1, ultrafiltration. Yep. That's it. Drive safe.